Yes, sir, we are live.
Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on the behalf of the entire team at MCure Pharmaceuticals. We at MCure are proud to present Cardio Colloquium, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected moderator, Dr. T.R. Murlidharan sir, Director, Institute of Cardiac Sciences, SRM Global Hospital, and Professor of Cardiology at SRM University, Chennai. Sir did successful implantation of Evera ISD and Advisa SC pacemaker first implantation in Chennai. He is also done first successful TAVI via trans-aortic route in the country. Leadless pacemaker implantation first in South India. Sir is recipient of Best Doctor Award given by Governor of Tamil Nadu, FICCI Best Innovation Award, and Kavinger Award by Chancellor of Sri Ramchandra Institute of Higher Education and Research. Sir has international fellowships to his credit: FACC, FESC, FIMSA, FCSI, and FRCP. Sir also participated as principal or co-investigator in landmark clinical trials like MUSIC, Hero 2, Create, Oasis 5, Oasis 6, Treat, and Freedom trials. Sir has 42 publications in national and international journals to his credit. He has also authored a chapter in book called Lipidology in Clinical Practice. Thank you, sir, for joining today. It is an honor for me to introduce our expert panelists for today. We have Dr. Prabhu Halkati, sir, Senior Consultant Interventional Cardiologist at Arihanth Hospital, Belgavi, Karnataka. We have Dr. Sadat Parid, sir, Consultant Interventional Cardiologist at Nizar Cardiac Center, Perinthalmana, Kerala. Dr. Praveen GL, sir, Consultant Interventional Cardiologist at SP Medifort Hospital, Trivandrum, Kerala. We also have Dr. R. Rajaram, sir, Consultant Interventional Cardiologist at KIMS Sunshine Hospital, Begumpet, Hyderabad. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with session on optimal selection of RASI in post-MI patients by Dr. T.R. Murlidharan sir. The meeting will proceed further with the panel discussion where Dr. Murlidharan sir will drive the discussion. In the end, we will take up few questions from audience. I request audience to put their questions in the comment box. Now I would like to invite Dr. Murlidharan sir to deliver his session. Over to you, sir.
Thank you, Dr. Rishikesh, for your kind words and giving me an opportunity to share the online podium with many of my good friends, eminent cardiologists across South India. At the outset, I have to special thanks to MCure to bring this topic, which is so dear to my heart because my days goes back to my DM cardiology days. My memory goes there, wherein there were times where primary angioplasty was not the order of the day. Even angiogram was not considered as a straight thing during an acute MI management. We had a lot of MI patients, thrombolized, many of them, not everyone, lot of LV dysfunctions, looking for medicines that can make a difference in their life. We were having very few drugs only. Not even clopidogrel entered the market. Aspirin was there. Lovastatin just sneaking into the Indian market. And we had this wonderful drug, apart from beta blocker, Ramipram. So the days were fresh in my mind, conferences, save, salt trial, everything. So thank you for bringing a nostalgic day. And I'll move to the topic. I'll share my slides. So today we are going to talk particularly on this thing, like what are we going to do in patients with, hope my screen is seen.
Yes, sir.
Are you able to see my
Visible.
screen?
Visible,
Yeah,
sir.
thank you. Thank you. So we are going to talk on optimal selection of ROS inhibition in post-MI patients. Today, I know not only the panel, many of our audience are aware of various drugs that can manipulate renin-angiotensin aldosterone axis, starting from renin manipulation to RNI and the gold standard AC inhibitors, and of course ARB, and particularly in the subset post-MI patient. And still, we are dealing with epidemic or pandemic, whatever you call, Acute coronary syndrome is one of the major things that haunts all the practitioners across the country who deal with medical cases or acute MI or critical care. So we are going to spend some time on the overview of various drugs, ARBs or RNI or AC inhibitor, and what the current guidelines suggest in this particular subset, post-MI. That's what we are going to start today. So let us start with angiotensin receptor blockers. What does the evidence say? We do use, but what does the evidence say? The key evidence comes from few trials only. For ARBs in post-MI, Optimal in 2002, Valiant in 2003, quite a large number of population, 5,477 or 14,703 in Valiant trial, and the drugs used were losartan compared to captopril, valsartan compared to captopril, and what we realized was no significant difference in total mortality by optimal trial number one, and we in patient Valiant trial combining valsartan and captopril actually worsened the adverse effects. Today we know this combination is no more accepted by any international bodies or government regulations. So looking at the optimal trial in myocardial infarction with the angiotensin 2 antagonist losartan, you can see the curves, how they merge. They have looked at the primary endpoints and secondary endpoints wherein sudden cardiac death or zinc, and the tertiary endpoints also. So no significant difference in total mortality in favor of captopril, number one. AC inhibitor should remain first choice according to that in patients after acute MI. Losartan cannot be generally recommended in this population. I'd like to remind my colleagues that it is a quite a old trial, 2002, but it remains very good even today for discussion. Same way, Valiant trial. Valiant trial wherein they were using valsartan versus captopril or valsartan with captopril versus captopril. Where there was a time where we thought the dual inhibition may be better, but in that mortality from any cause or cause-specific mortality is similar in all the three different groups, as we see. The rate of secondary endpoint like death from cardiovascular causes or recurrent MI or hospitalization, again, no big difference at all. So we realize ARBs not inferior or never proved its superiority. Of course, in many other settings also, that is beyond the scope of today's discussion. So that is one side. Coming to ARNI, the one which we have been using quite a lot in heart failure, how does it perform in a post-MI setting? That's why we're going to see. Few trials are available. One of the classic trials is Paradise MI, wherein ARNI following acute MI, primary is the Paradise trial. It was in 2021, it was 2021, it was published. A good, well-planned trial wherein patient with acute MI from 12 hours to 7 days with a EFR less than 40% with or without pulmonary congestion. But any of the one risk enhancers, either elderly person more than 70 or EGFR less than 60, diabetes or prior MI, atrial fibrillation or LVF much more less, like less than 30%, is class 3 and STEMI without reperfusion. The major exclusion was prior heart failure, clinical instability, and very low EGFR less than 30. What they were comparing was sacubitril valsartan combination. It's something like we are going to give 200 million BID was the thing in 2,830 patients, and Ramipil 5 mg BID, that's the highest was 10 milligram. Even driven trial, 711 primary endpoints that we are looking for in a median follow-up for 23 months. The primary endpoint was CV death, HF hospitalization, and OP development of heart failure. Secondary endpoint was CV death or first heart failure hospitalization. Published in 2021 in the European Journal of Heart Failure. And the primary outcome when we see CV death or composite endpoint, HF in hospitalization, outpatient HF, no significant difference. The P value was not significant at all. That is the point number one we learned. And coming to the various things, secondary endpoints also, if you look at it, each one, the difference was not significant at all by the p value. We can see the incidence rate is almost similar. So it indirectly proved that the drug ARNI, which was a wonderful drug, we have been using it in many other heart failure, somehow did not behave or perform very well in acute post-MI setting in this particular trial. And the adverse events are comparable. They were nowhere superior in reduced adverse event. Rather, in fact, an increased number of hypotension compared to the Ramipil group, and the statistically insignificant number of cough and both the group and renal impairment were similar, hyperkalemia was almost similar, and other abnormalities were similar only. So to summarize, ARNI or sacubitril valsartan did not result in a significantly lower rate of CV death, heart failure hospitalization, or outpatient heart failure requiring treatment. Number two, the pre-specified observation of reduction in both the investigator reports of the primary composite as well as the total adjudicated event support incremental clinical benefits of sacubitril valsartan. And the safety and tolerability of sacubitril valsartan in this AMA population was comparable to that of the ACI as we saw in the previous few slides. So several reports, several discussions, various medical groups, everything that post-Lisa MI, we realized that sacubitril valsartan could not beat and the standard AC inhibitor like ramipril in this particular subset. So that is the second thing. So we saw ARBs, we saw ARNI, and moving into what AC inhibitor did. Though old trials, very good trials like selective things are a broad one. We are looking for save or air or trace. They use for higher risk long term or a broad one short term like consensus, GC and ISIS. Here I think trace used trandolopril, air and save used different drugs like captopril and ramipril. The same survival and ventricular enlargement trial 1992, one of the very good trial of that time where it compared captopril versus placebo. In a randomized double-blind trial, MI with EF less than 40% between 3 to 16 days, we were using Muga those days. Now it is very rarely being done. Captopril 15 mg TAD was a placebo. For a mean period of 36 months, up to 60 were followed up. There was a 19% reduction in mortality and 20% reduction in recurrent MI. The enlargement of the ventricle was comparably less in the active arm group, and these benefits occurred equally in patients who received thrombolysis or beta blocker. As I said in my initial introduction, there were no primary PCI available at the time. Coming to trandolopril in cardiac evaluation trial, what we saw was the design, randomized double-blind placebo-controlled multicenter trial, acute MI with wall motion index of then 1.2 random between 3 to 7 days. Trandolopril, which is not being used nowadays, and we didn't use for some reason, never seen Indian shores. Follow up for 24 to 50 months, 20% reduction in mortality, 15% reduction in recurrent MI, and 20% reduction in sudden cardiac death. That is in 1995 in New England Journal of Medicine. Oh, some reasons are moving. Yeah. Other evidence for ACI, we had ISIS trial, GC3, CCS, all those things, where we were using captopril or lisinopril or anti-infectious captopril group. All these things showed a significant difference in the group. In particularly the AR trial, which was an acute infection, ramipril efficacy, the relative risk was 27% with a significant p-value. That's what we see. This is one of the few trials which made us, or not only me, across the world cardiologists, to rely on ramipril in a post-infection setting. AR extension was followed up for a longer time, from 42 months to 59 months. The safety and efficacy was progressively continuing. That's the interesting thing we saw. So the beneficiary of the ramipril was progressive in AR extension trial. You can see the beneficial of started early after MI with heart failure, sustained over 3 to 4 years, despite continuation of medication after 1 year. The relative risk reduction in mortality was 36% and absolute risk reduction was 11%, which is something rare we can achieve in today's day. So treating every 9 patients with ramipril for an average of 1 year will result in one additional survival for 5 years. That is one encouraging finding we see. Ramipril long-term survival benefit in acute MI patients, air survival 2021. There's something mind-boggling. I think after 29.6 years after randomization, the magnitude impact on length of survival observed after treatment is ramipril. That is the same dose, 5 BD. So air study followed up to that long period. The patient number of 603, inclusion rate the same as the air inclusion. No other intervention, approximately 30 years. Life expectancy or all-cause mortality of seen. You can see the benefit started persisting for a very long time. Median survival time was 8.3 years. Interestingly, even in placebo group and 9.6 in ramipril group, life survival curve crossed at 14 years from the time of randomization. You can see here, somewhere in this point, the survival curve crosses it. So extension of life is by 14.5 months. Life expectancy improved with ramipril across all comorbid groups in this group whenever we go through that. So in diabetes, previous MI, history of heart failure, or hypertension, angina are more than 65 or less than 65. So in all these groups compared to placebo, there was a significant change in the efficacy or outcome. So substantial survival gains with ramipril treatment for 15 years beyond the blinded treatment allocation. To put the other way, for every day a patient receives Ramipil, on average, his or her life was extended by a further day. Relative risk survival for patient diabetes was increased by 54%. Patients with diabetes, previous acute MI, previous heart failure, hypertension, and angina each benefit on average from AC inhibition and treatment with Ramipil for about 1 year when started early after MI. In patient heart failure, there is a survival benefit which is sustained over many years and offers an average and extension of life of an additional 1 year. So to conclude, treatment with Ramipil for about 1 year but started early post-MI in patients with heart failure results in survival benefit which is sustained over many years and offers an average and extension of life an additional 1 year. So, what do the current guidelines suggest? So, we know all these drugs, ACE inhibitor, ARB, the ARNI, all we have seen. What the current guidelines suggest? By seeing one of the papers in 2018, where we know index MI, today immediate reperfusion, which was rarely done at the time of thrombolysis was thing. Early revascularization for cardiogenic shock and initiate AC inhibitor in the first 24 hours. Second thing is avoid beta blocker for first 24 hours for ongoing heart failure. We have other trials, comic trial, other trials, which will reserve it for discussion. And the early interest aldosterone antagonist benefit time dependent, which are first 7 days. Re-evaluate eligibility for beta blocker therapy when you are not started to restart or start it. It is critical to titrate dose of medication to optimal level post-discharge. This is how we looked at it. So, the one of the first drug after revascularization, even today, we would like to use will be Ramipro. So, AC inhibitor should be administered within first 24 hours. The EF is less than 40. In heart failure patient, if the EF less than 40, significant survival benefit confirmed on the first day of treatment. That is one thing we know by these trials. And by 2020 guideline, not old ones, 2020 ESC guideline for management of ACS in patients presenting without persistent ST7 elevation, AC inhibitor or ARB if the AC inhibitor are not tolerated or recommended patient heart failure with reduced LVEF less than 40, diabetes or CKD unless contraindicated. That means hyperkalemia or severe renal impairment in this group. That's a class 1 indication with a level of evidence A. Something like February 2025 recommendations, ACC-AHA guidelines. You see class 1, again level of evidence is A. In high-risk patients with acute coronary syndrome, LVF less than 40, hypertension, diabetes or STEMI with anti-allocation, and oral ACE inhibitor or an ARB is indicated to reduce all-cause death or MACE. In patients with ACS and LVF less than 40 and with HF symptoms and diabetes, we add MRA. And they nowhere there's a mention of ARNI in this group because we know they are looking for maybe a new trial or maybe some new evidence to make us to believe or emphasize our need to use the thing. So to conclude, we have been using RAS inhibition effectively to help the patient to improve survival, to improve the morbidity in acute MI or heart failure patients. Though many of those indications are taken over time by ARBs or ARNI, one area that remains for reserved for AC till today will be acute MI, and that's the same thing being discussed today. I'll open with this thing the panel discussion. Thank you for all. Shall we move to the panel discussion, sir? Shall I?
Yes, sir. I would
Okay.
invite you to drive the panel discussions. Thank
Yeah,
you.
yeah. So maybe I'll start with Dr. Prabhu. I thought I'd type the question for the benefit of audience also. Dr. Prabhu, I'd like to bring your expert insight into this thing. In the post-MI patient after revascularization, at what blood pressure do you initiate ACE inhibitor therapy? What is the starting dose would you like to recommend? And how do you uptitrate the dose? Because there's one thing that is challenging many of our physicians, amount of inhibition or inertia is there when there's a mild hypotension. Could you please elaborate on that, sir? Thank you.
So in my practice, when I have an extensive interval MI, we take them for, if they come in time period, we take them for primary angioplasty. If they are late, then we go ahead with the thrombolysis. But echo is definitely done immediately. Either any of the revascularization is done. Echo when we do it, if a patient is having severe LV dysfunction and blood pressure is maintained say around 110 or 120 with a diastolic of 80-90. So if the systolic blood pressure anything more than 110 or 120, starting an AC inhibitors on the day one is not a problem. But in case a patient is in cardiogenic shock with a blood pressure of 70-80, it may be difficult for us to start the ACE inhibitors because he will be on supports. We may have to sometimes put on IBP or inotropic supports. Still, the pressure is definitely more than 110, 120. Then only I will start with the ACE inhibitors. So, especially ACE inhibitors, ramipril is the one drug which sir has already told. We start with maybe 1.25 and then 2.5 milligrams, increase the dose maybe if the pressures are maintained well, and upper limit is maybe 5 milligrams BD. But titrating has to start with maybe 1.25 or 2.5 minimum once a day. Then you can make it second day if the pressures are still holding well. Then you can make it 2.5 BD on the second day. Third day, I will go for optimal therapy of minimum requirement of 10 milligrams. But in our Indian setup, I have seen tolerating up to 10 milligrams of ramipril are very, very difficult because they are all small surface area. And most of them I have seen the pressures will go down when we jack up the dose to 10 milligrams. And that is the starting dose and how I titrate over a period of maybe 2 to 3 days. That is how I make it. Because we don't want to reduce the systolic pressure much lower so that coronary perfusion will be hampered. Anything else, Muralidharan sir?
Oh, thank you. Thank you. Nicely placed your point. And as you rightly said, over years we learned that if we start a low dose, if we watch for a first dose hypotension, if it doesn't occur, very rare we do see that in the subsequent escalation dose. Of course, we go slowly, as you said, within 3 days, sometimes even longer time also. But that gives you an excellent safety margin and confidence also. So I always use at 1.25 mg only to begin with, carefully watch the patient. But sometimes I have used even at systolic BP 100 also, it's a careful watch. That's one thing. That's a very nice point. Is there any question about this in the panel? We can address it at the end of it. Thank you. Thank you, Dr. Prabhu. Thank you very much. Maybe we'll move to the next question. To Dr. Sadat Parid, will you switch the patient on AC inhibition if the patient at the time of MI was receiving the ARB for hypertension? This is a common scenario we do see. Many of our acute MI patients, they were on some sort of an sartan on either optimal dose or suboptimal dose, control or whatever the situation may be. But if they are on a sartan, ARBs, at the time of MI, what will be your line of approach if they come with acute MI? Of course, you will be doing all standard care, revascular, everything, but will you switch over to AC inhibitor? The question, the floor is yours, sir, please. Do we have Dr. Sadat in the panel, sir? Yeah, we are not able to hear him. Dr. Rishikesh, is he there in that thing?
Yeah, Dr. Sadat had joined. Sir, are we audible to you?
No, Valmi not audible.
I did see him in the faculty list.
I think.
I joined Rishikesh.
Yeah, Dr. Parid had joined, I think. Dr. Parid, sir?
If you're not there, we can only discuss only that.
Yeah, certainly. Maybe the other panelists with the thing we can discuss. Would anyone, any other panelist would like to take this question and answer?
No, I personally feel we don't continue with the ARBs when the patient has already had an MI. Even though he is on antihypertensive with ARBs, I preferably change over to ramipril. This is what I am practicing. Maybe I don't know, Muralidharan will agree for it or not. Because definitely some of the studies have shown that AC inhibitors are much better compared to the ARBs. So I usually switch over to AC inhibitors.
I fully agree with you, sir. The same thing I do. Particularly if a person on ARB develops an acute MI, of course, there are MI paradox which remain unproved only by a larger meta-analysis and thing. There is no restriction on that. But still, when I come across a patient with acute coronary syndrome, my intention will be to move into AC inhibition in the group. Again, as you said, look at the clinical profile, like previous question we discussed. Look at the clinical profile, look at the hemodynamic stability, try to restart the drug at a dose that is recommended. Sometimes we do have the comfort zone in this patient who are hypertensive, that BP may remain quite good. Our starting dose can be higher, or we can escalate to higher doses quickly for not only to reach the optimal dose, but also to control the blood pressure. So the idea will be moving to AC inhibitor, maybe a drug like Ramipral, which is commonly used. I know some centers do use Enlapril. I prefer Ramipral in a patient with acute MI who is receiving ARBs, and never combine. That we know very well, never to combine both the things. That is how it stands. Thing. If there are no other suggestions or comments from the panelists, maybe we can move to the next question. Shall I?
Yes, sir.
Thank you. Thank you. Okay, this question is to Dr. Praveen. How early do you think an ORNI can be initiated in a patient post-MI? This is an important question because we are seeing a lot of patients who need heart failure management. We are giving them standard drug like AC inhibitor in this group as we are thinking. When would you like to change? How early would you like to change? The question is to Dr. Praveen, sir.
Rishikesh?
Dr. Praveen sir, I think maybe he lost the connection. He joined.
Mhm.
Dr. Praveen sir, I think he lost the connection. He will join again.
Muralidharan, sir.
Yeah.
So that's
Shall we
maybe
discuss ourselves
only
or shall we wait for that?
we only have to discuss the whole
Okay.
thing. Maybe
Okay.
I mean this is my thing. What I am practicing, whether it is wrong or not, I think Muralidharan should guide us. When a patient has an acute interval extensive MI, I have done an echo. It is showing severe LV dysfunction, and creatinine and all is normal, right? So, but ejection fraction is about 30%, 35%. Pressures are okay. Hemodynamically is stable. Creatinines are within normal limit. Now, initially, we start with AC inhibitors like Ramipril, which I told you. Maybe before I discharge the patient, because I need to stop AC inhibitors at least around 36 hours before we start ORNI. So I have put some of the patient before I discharge them, maybe a fifth day or sixth day or 1 week later. We put them on ORNI, starting with 25 milligrams BD and then jack up to 50 BD or 100 milligrams BD, depending upon how it tolerates with the blood pressure. This is what I am practicing. I don't know. Muralidharan sir should help us to if there is any clarification to be done.
Definitely, definitely. In most of our patients, now when there's established heart failure, our intention will be to go for ARNI, and the timing of initiation, as we saw by our evidence, other things, though there are some trials which did with ARNI in acute myocardial infarction, they could not prove their safety or efficacy in that group. So currently, start with AC inhibitor, you can move into ARNI. Sometimes we may start ARNI straight away. That depends on the situation. Most of the time, we want to think. The same, again, the Paradise MI is the only best trial available. The one challenging thing that we may come across in this situation is I have a patient, I have started AC inhibitor on day one. I've been following him up. He is stable or unstable with LV dysfunction, with or without evidence of congestive heart failure. I want to move to ARNI. One limiting factor is I can't straight away change over because I need at least 36 hours of time, sometimes 48 hours, to move from AC inhibitor to ARNI, as recommended in all these groups. So, what do I do is if the patient very, very stable, we may take that time. Sometimes we may be bridging that time with an ARBs also, though they are not proved to be superior in this. You move from AC inhibitor to ARBs, from there move to ARNI. So our intention to use ARNI, to be frank, in this group is really high. They are having persistent heart failure. But most of my patients, by default, they have started on AC inhibitor on the day one. So we move carefully. That's what we do. So you can initiate as early as possible, provided the patient needs it, otherwise over a period of 1 to 2 weeks. I think, are there any comments on this, or I can move to the next question? Maybe I'll move to Dr. Rajaram. Rajaram was there. Welcome. Good evening, Rajaram. Regarding post-revascularization, if you find the EF is less than 40, but without obvious heart failure, what will be your take on this? Will you put the patient on AC inhibitor or ARNI? Quite a question of dilemma that we face among our physicians. Looking for your answer, sir.
Hello.
Hello?
Yeah, I'm Dr. Sadat.
Yeah, sir, just now we moved out of your question. We may come back for maybe one other question if there is. Dr. Rajaram is supposed to answer this question. Dr. Rajaram, are you there?
Okay.
Dr.
Sir, Rajaram
Rajaram,
sir,
sir, you are
you
on
can
mute.
unmute, sir.
Yeah,
Please.
sorry. Yeah. Good evening, sir. Good evening, Muralidharan, sir. Good evening, other co-panelists. Am I audible?
Yeah, you are audible.
Yes,
You are
sir.
audible.
Yes, sir. You are on.
Thank you. So, regarding the question, in the post-revascularization situation, whether the patient is having clinical heart failure or not, if his ejection fraction is less than 40%, then I would directly straight away go with the ARNI, sir, because the Paradise MI trial has clearly shown that there is no inferiority when compared with the ACE inhibitors. First thing. Second thing is it has proven that safety and efficacy in it is comparable with the ACE inhibitors. First thing. Second thing is it has got incremental benefit if you escalate the dose. Third thing, if you start the ACE inhibitors, because this question was almost similar to the previous question, where immediately in the first day whether you would like to start the ARNI or not. My intention, my practice is usually I'll go with the directly if the ejection fraction is less than 40%. If the patient is having, is there any concern of hypotension? If the patient is not in shock, then I would like to go with the ARNI only, sir, because there is no question of interruption of ACE inhibition coverage. If you start the ACE inhibitors, again washout period of at least 36 hours should be maintained. So that is the highly unlikely during the acute intensive phase, for at least first 1 week or 2 weeks or so. So it is both because we have a evidence of Paradise MI trial. So it is safety, efficacy wise, as well as incremental benefits with the sacubitril valsartan combination. And other benefits are mortality benefit or first hospitalization for heart failure and everything is similar with the ACE inhibitor. So unless my concern is hypotension or shock. Otherwise, I will start low dose with the ARNI. That is even I would like to go with the 25 milligrams of ARNI. Then gradually I escalate depending upon the tolerance of the patient. So that will be my, irrespective of whether patient is in clinical heart failure or not. If the ejection fraction is less than 40, I would go with the ARNI. If it is above, if it is suppose if it is a mild LV dysfunction and all those things, I may go with the ACE inhibitors and followed by, if necessary, depending upon the clinical situation, I may turn up to the other arm. But when it is less than 40, I would like to go with the arm only, sir, initial upfront.
Fair enough, sir. No, almost the overlap of previous question and this question,
Yes,
and
sir.
how the
Same.
patient is situation. You
Yes,
can
sir.
either one thing. But if without any clinical heart failure, still you would like to go on ARNI or would like to give a trial of ACE inhibitor? With
Yes,
heart
sir.
failure, no doubt. You
Yeah,
like
yes,
to.
the latest guidelines also recently when ACCH guidelines as published in the February 2025, where they clearly they have mentioned that it is a class 1 indication irrespective of if the patient falls into high risk like diabetes, hypertension, CKD, and interval MI with ejection fraction of less than 40%. All these things are high risk patients. So if the ejection fraction is less than 40%, immediately you should go with the ARNI only, sir. ARNI is the first because it is replacing the ACE inhibitor, sir. That was the guidelines say.
Any other points? Anybody would like to add their experience or their idea? No further question. We're wanting for the whole panel now.
Yeah.
All of us can pitch in. Tadat
Yeah,
also is with
hello.
us. Hello?
Yeah, I'm
Yeah, I'm
Dr.
coming to
Sadat.
you only, sir. This question going to be starting with you only. In the post-MI patient, after revascularization, we have other drugs also. When do you like to start a beta blocker? which will be a preferred beta blocker, and what dose you initiate and how do you uptitrate? Will you advise an AC inhibitor with beta blocker combination? Let me start with Dr. Sadat to answer the first point. When would you like to start a beta blocker in this group? Having we covered AC inhibitor and the RNA in the last few minutes, could you please throw light on this, sir?
Yeah, I'm Dr. Sadat, cardiologist. Hello?
Yeah, we
you
can
are
hear
audible, sir.
you.
Please.
Yeah, regarding post-MI patients, mainly worrying about their blood pressure status because of acute MI status, LV dysfunction in presence or not. If the patient is having LV dysfunction and blood pressure is more than 100 and 120 above, stable patients, most of the patient time, we will start ACE inhibitor.
No, regarding beta blockers, sir. Regarding beta blockers.
Yeah, beta blocker again, if the patient is having LV dysfunction with tachycardia, heart rate is more than 100 above, or if the heart rate is below 50, we will wait for a response of the heart rate increment. If the patient is having tachycardia or LV dysfunction, we will start beta blocker.
Yes, sir. So, important things like as Dr. Sarat rightly pointed out, in a person with obvious congestion, congestive heart failure, acute pulmonary edema in this situation, we would like to avoid beta blockers in the first 24 hours. As we were seeing the one of the slides, the idea will be looking at the patient when to start,
Yeah.
how early to start in the next several days, because we know it has a definitely beneficial effect. Start it judiciously. The other few points to be looked at is presence of second degree block or more than that. Definitely, we are not going to use it.
Yeah.
Up to first degree heart block, yes, we have a chance, but where also we carefully observe the first degree
Yeah.
heart block. So this combination. So that is how we start beta blocker, which will be your preferred beta blocker. May I ask this question to Dr. Sarath himself before moving to other panelists, since our this
Yeah.
question initial. Which will be a preferred beta blocker, sir?
Usually, my practice, I am starting with metoprolol.
Okay.
Yeah. Or sometimes we will start bisoprolol.
Okay. That's what. Most of us also, people who are early things, we love to stick with metopol mostly, and bisopol came in. Pure heart failure, we were moving into cardiac, other things, but I take it. I would like to ask other panelists also in this about the type of beta blocker, the dosage they would love to use.
Yeah, only the answer.
Yeah.
Anybody else is answering, or I'll just tell my preference of what.
Please, sir. Waiting for your answer, sir.
Whenever there is a patient with acute MI, PAMI has been done, extensive interval, or we have done a thrombolysis. If the LV function is poor and his pressures are maintained above 100, preferably, I definitely, if the heart rate is, say, tachycardia is there, extensive interval, less than 40, beta blockers definitely has got a role. And my first preference is always I start with metoprolol, maybe 12.5 milligrams BID, and then maybe next day or third day, if the pressures are still maintained, if the heart rate is still higher side, we jack up to 25 milligrams BD, and up to 50 milligrams BD is the upper limit what we have practicing. In case if LV is very bad and the whole area there is a scar and MR is there, patient is symptomatic with a heart failure, then carvedilol also is a drug of choice along with other drugs like AC inhibitors and diuretics. So I sometimes put them on carvedilol, maybe 3.125 BID, and then depending upon the pressure and heart rate, we can jack up to 6.25 or 12.5. So that is the titration of these two beta blockers, either metoprolol or carvedilol. And the last question which you asked me, there are definitely most of the cases of mine where there is a severe LV dysfunction and not in cardiogenic shock. I do combine both AC inhibitors and beta blockers. Maybe beta blockers in the form of either metoprolol or carvedilol and ramiprazole. This combination definitely with the diuretics, of course, there is no doubt. Diuretics has to be added, and some of them I do prefer this eplerenone. maybe 12, 25 milligrams of BD and other drugs are added. So this is how I am practicing till now.
Certainly, sir. I think you covered the third question also to bit. We all prefer that way only. And this combining, will you advise an AC inhibitor plus beta blocker combination? Maybe this is also for all the panelists, all of you can answer. I will put this question into two ways. One is giving it as two separate medication, separate tablets, or using a combo in the situation. I'm just trying to pull your legs to get your teach you all to get the answer. That's all. Don't mistake me. Let's be benefit. We do have this combination freely available, individually available. So what do you use? How do you use this combination? Thank you, sir.
Yeah, I would like to go with the initially we start with the separate only, sir. Because the first day itself, both beta blockers as well as ACE inhibitors are indicated definitely if there are no contraindications, as we have Dr. Prabhu sir has rightly discussed about the various contraindications. First of all, we have to see the contraindications are not for both beta blockers as well as ACE inhibitors. If there are no contraindications, then we should start isolatedly, then escalate as the patient tolerates it, depending upon the clinical condition. Once our target doses are achieved, both in the ACE inhibitors as well as in the beta blockers. Depending upon that, then you can put as a single pill. The single pill combination is always preferred by the even guidelines also it has given the 2A. That means it is more preferable to increase the patient's tolerability and effectiveness is very good with the control of either for the sake of hypertension or for the sake of control of the heart failure, morbidity and mortality benefit. So its tolerance is good, the side effects are low, effectiveness is very high, and then so their acceptance is also very well if you put a single pill combination. So initially I start with the isolated tablets and gradually escalate the dose. I will see where the patient is tolerating which dose. Then we can convert it into the single pill combination. So that will be my approach for the last question, sir.
Thank you. Thank you. Any other points? Would anyone like to add? Dr. Siddharth or Praveen? Okay. Maybe go to the next question. So again, this question is to Dr. Prabhu. Do you consider NT-proBNP as a deciding marker for choosing RNA or ramifil?
No, I will definitely not decide on this BNP factor. We can use either ORNI or ramipril, any one of them, but we need not have to, because most of the heart failure patients have higher NT-proBNP level, but it is not the deciding factor to choose whether it is ramipril or ramipril. So I will not agree with this. So you can use either ORNI or ramipril, any one of them, no problem.
For me, sir, NT-proBNP, if it is very high, probably we may go with the RNA, sir, because already this transition and then this trials as what is that pioneer trial or something like that. So those two trials has clearly shown that it is RNA has reduced the NT-proBNP almost 40% by end of 6 months or so. So NT-proBNP levels are significantly reduced with the RNA when compared with the ACE inhibitors. This was already tested this transition trials and this pioneer trial or something. So those two trials has clearly shown that NT-proBNP reduction is much more better when compared with the ACE inhibitors. So as per se, for the sake of NT-proBNP is high, RNA should not be taken, but definitely the RNA has got edge over the ACE inhibitors if you are concerned about the NT-proBNP levels. Obviously, when it translates into the clinical heart failure, when NT-proBNP is high, obviously the patient will be in the clinical heart failure. So clinical heart failure is much better controlled. Again, go back to the previous one. When the ejection fraction is not only less than 40%, wherever the ejection fraction is the clinical heart failure does not correlate with the ejection fraction itself. It may be diastolic heart failure, may also leads to heart failure also. So in this case, The NT-proBNP per se, if you take, I think ARNI is the better option. So I would like to go with the ARNI only, sir. If the NT-proBNP is very, very high, then I would like to go with the ARNI so that by starting the ARNI, I can reduce my NT-proBNP levels. Initially only in the first 1 week itself, it is first 1 day itself, more than 20% reduction in the NT-proBNP is demonstrated in those trials. And over the period of 6 to 9 months, almost 40% of the NT-proBNP was reduced within those trials. So I would like to go with the ARNI, sir, instead of ACE inhibitors.
Okay.
I agree. See, it's like this. We are seeing NT-proBNP as an evidence for a overt heart failure.
Yes, sir.
A significantly elevated NT-proBNP. Like sometime back, the 2025 trial also, there also the trial clearly said, if a patient comes with LV dysfunction without any evidence of heart failure, you can still wait on ACE inhibitor. But when you come across an ACE inhibitor, acute MI, low EF, and heart failure symptoms, Sacubitril valsartan combination seems to be a preferred option because it has proved to be safe. It is proved to be non-inferior, and the other trials have said it's good. So, not only reduction NT-proBNP, overall outcome is better. So, in that case, we see that NT-proBNP as an evidence to move from ACE inhibitor to heart failure. I fully agree. So, we consider NT-proBNP is a one deciding point in the situation. I agree. Anybody else would like to add interesting there? If there are no questions, maybe I'll try to move to the next question. To Dr. Sadat again. Will you start an ACE inhibitor in all patients with acute coronary syndrome, whether revascular procedure was performed or not, to get the mortality benefits? So the question is here, you are giving a drug not for just for LV remodeling or symptom relief or other things, to look at the mortality benefit. What will be your take on that, sir? Dr. Sadat, are you there?
Yeah, Dr. Sadat had just joined. He was
Okay.
facing some network issue. I think he had joined. Dr. Sadat, can you hear us?
Dr. Sadat is here.
Dr.
Would
Sadat,
you like
sir,
to
this
add on
question
this
is to
particular
you.
point? We are looking for your insights. So for a straight mortality reduction, we saw the trauma trial also. What do you think, sir?
I don't think he is able to hear us.
Yes, yeah, there's some. Oh, we could. I mean, we are not able to hear him, I think.
Mm-hmm.
Sir, can you unmute and give your answer, sir?
Dr. Sadat, sir, can you unmute? And yeah, he had joined. I think.
Now I think.
Yeah, he had joined from other device. Okay.
Yeah.
So this question is.
Yeah, most of the time, if the patient is ACS patient. Hello?
Yeah, you can tell.
Yes, sir, you are audible.
Yeah, most of the time, ACS acute MI patient, if the patient is hemodynamically stable, blood pressure stable, or if the patient is having LV dysfunction, echocardiogramic LV dysfunctions, and without any pulmonary edema status, most of the time we start with AC inhibitor.
What about Dr. Rajaram? What do you think about this?
Yes, sir. So I fully agree with Dr. Sadat because in ACS situations, particularly ACS situations, irrespective of the LV dysfunction or high risk factors, it can be started from the first day itself. It is a class 2A indication. If the patient is having high risk features like hypertension, diabetes, CKD, or STEMI with the anterior wall MI, or if there is an LV dysfunction or clinical heart failure, these factors are high risk features where it goes with a class 1 indication. Otherwise, for the protection of this cardiac protection effect, all ACE inhibitors have shown that it has got a cardioprotective effects by preventing the cardiac remodeling. So that is the reason in ACE inhibitors, irrespective of your ejection fraction or other things, particularly in ACS situations, it is a class 2A indication. ACE inhibitors has to be continued at least for the 1 year.
I think even most of the studies have shown that there is a mortality benefit also by use of
Yes,
ACE.
yes, yes.
Yes, sir. Mortality as well as basically it is a cardioprotective effect.
Hmm.
In other situations, mortality benefit basically seen in the less than 40% EF patients.
Hmm.
But in others, it is a cardioprotective effect. So it prevents the cardiac remodeling and all those things. It prevents the damage to the endothelial protection, decreases the inflammatory actions, decreases the vasoconstriction, decreases the LVH. So these are all the other beneficial effects of the ACE inhibitors. So that is the reason it is called cardioprotective effect. Mortality benefit is seen only in less than 40% of the AF patients.
Can we go to the next question, Muralidharan sir or Rishikesh?
Yeah, sir. I think one more question, one or two more questions. Dr. Muralidharan, sir.
Next question.
I'm coming. Can you read the next question for me? I'm not able to see in my screen. Can
Okay.
someone read? Are you able to see?
Yeah, I'm able to see.
Yeah. Why don't you read the question? I'm not able to read. That's why some problem here.
No, next question has not come. Sir.
Next change.
My
Next slide.
screen. Yeah. Okay. Here it is. I'll come to that next question. Somehow it's not
Should
working.
I share my
Yeah.
screen?
Can you do that for me? If
Yeah,
someone can do it for me.
Rishikesh can change
Yeah,
that.
yes, sir. I'm sharing. Sir, is my screen visible?
Yeah. Visible very much.
Yeah.
Yeah, correct. Yeah.
Yeah. This is a very nice question. What percentage of your patients tolerate ARNI, randomly on BD dose versus the Ramipur? I'll put the question mild rephrasing. We all have been using ARNI. How many of your patients you could reach 400 milligram a day?
No,
I'll put that way.
I
How
never,
many?
I never done.
Anyone can. I'll start with Prabhu. How many of your patients? What percentage?
not even single patient.
Yeah. Rajaram?
100
Sir, my
milligrams
patients,
BD.
Ramiprin 5 mg BD, my patients are there, sir. Those are all
Yeah.
the
No,
hypertensive
200
patients,
mg
actually.
Yeah.
Ramipur.
Yeah,
Ramipur, many of us would have
hardly
reached 10
5%,
mg.
hardly 5%, sir.
Always.
3% of my post ACS patients, those who
Yeah.
are hypertensives, I don't want to change the ACE inhibitor. So I'm continuing Ramiprin 5 mg BD for them.
Okay.
Only 5%. And I never prescribed this 200 mg ARNI for any patient in my life.
No, no.
So only 100 mg BD maximum.
100 milligrams BD.
100 milligram BD, yeah, that is
Yes.
maximum.
So 100 milligrams daily BD is the maximum dose I have achieved for my patients. But
Very
5
good.
mg BD, I think 5% of my patients are having 5 mg BD of Ramit.
Okay.
Just for the sake of hypertension control, and some of them are my old patients actually. 15, 20 years onwards, they are on the ACE inhibitors only. So they doesn't want to change it. So okay, I asked them to continue the same thing. That's it.
Praveen?
Dr. Praveen, I think he is facing network issue, so he couldn't rejoin.
So now Ramipral 500 milligrams BD, Orni 100 milligram BD. That is the upper limit of the dose what we are all using it.
For me, is exactly the number is not percentage, 8 patients.
8, is it?
8 patients. Of that, 2 are waiting for transplant. They could not get their heart. They died also. Other 6 patients are on that. Interestingly, almost all the 6 patients who had a significant amount of hypertension before developing LV dyspnea heart failure. So this worked as anti-hypertensive. I could reach the dose. So number is not percentage. Only 8 patients. If I'm talking about the last more than 10, 12 years. Yeah, something like that. Maybe next question. Are there any more questions?
So,
Oh, yeah, the last
sir,
thing.
there are few questions in the chat box.
We'll
One or two
answer.
questions, sir. With your permission, we can take up
Yeah,
those.
please.
Yeah,
Can I
go
open
ahead.
it?
Yeah, you can click on the chat, which is at the
Yeah, I could
bottom.
see that.
Yeah.
I could see that. If patient is on telmisartan after MI, should we switch to AC inhibitor or why? I will give the question. I'll request Prabhu to do the answer.
This is the question answer list side.
So
Huh?
you can click on the chat, which is at the bottom of the
New
screen.
chat. New chat.
Chat. Yes, sir. You can click on the chat.
Okay. New chart. Few questions.
Yeah, third question.
Can you repeat, sir? Because I'm not able to see it. Question.
Question number 3, sir. If the patient is on telmisartan, after MI, should we switch to ACE inhibitor and why?
No, normally I just continue the same telmisartan only. Otherwise, most few of them we have done a change if the pressures are on the higher side, and we have continued 5 milligrams PD of ACE inhibitors because most of the studies have shown much benefit with ACE inhibitors rather than telmisartan.
Okay.
Majority of them they are on Ramipral. I don't know about other people. What do they say?
Yeah. Now we saw this thing in our discussion also. So we prefer to use ACE inhibitor posting. The second question is in high CV risk patients, which RAS inhibition beneficial, ARB or ACE inhibitor? The answer is open. Maybe I'll request Rajaram, can you please elaborate on this, sir?
Yeah. Already we have discussed completely, sir, regarding this high risk patients. All high ACS or ASCVD risk patients. ASCVD risk question, sir.
Probably
ASCVD
should take
risk.
it as ACVD risk only.
ASCVD risk patients also it is a ACE inhibitors or ARBs. Both are effective. Both are effective. Some of the there are no exactly conclusive, but some of the trials with the on-target trial, if you see telmisartan and all those things, it has got because of pleiotropic effect, both on the effects on the endothelium and the because of cardioprotective effects. So ACVD patients has to be on the ACE inhibitor, sir. Just for the sake of this cardioprotection effect, ACVD, all ACVD patients, they have to be on the ACE inhibitors.
Yeah,
It has
interesting.
got a
That's
plaque
what.
stabilization effect, anti-inflammatory effect. It reduces the vasoconstriction. It decreases the LVH. It decreases the smooth muscle thickness and all those things. So pleiotropic effects are there with the ACE inhibitors. So if the patient is tolerating, if the patient is hypertensive, you can go with the ARBs because blood pressure reduction is more with the ARBs. Or else, if you want to have a protection, then you can go with the ACE inhibitors. Not only the ASCVD, and particularly suppose if you see the diabetic patients. In diabetic patients, you give ACE inhibitors for the cardioprotection. So those beneficial effects are clearly shown in the trials. So that is the reason we give in all ASCVD patients, ACE inhibitors have a very good protective effect. So we have to give.
Correct.
But looking into this, one way is when this on-target trial only, that was one of the trial which was widely talked and made telmisartan one of the very popular sartan. They compared with Ramipril and they found non-inferiority very clearly proven. Non-inferiority was proven in the trial. And interestingly, in the trial, there was a subgroup. There was a subgroup of patients who were, sorry, my battery is down. There are a subgroup of patients who are AC intolerant.
Yes.
So what they did was they thought that group they will compare with the placebo. So we have Ramipril versus telmisartan, and patients who had intolerance mostly due to cough or angioedema, they said let us not give AC inhibitor at all. We'll compare placebo. When we saw on-target trial, the non-inferiority proven, everyone was expected the other trial where they have taken us, I think, what we call transcend trial. ARB should prove superior to placebo because it's not Ramipur anymore. But interestingly, again, it was non-inferior only. Surprising. So one side we say Ramipur is equal to telmisartan or telmisartan equal to Ramipur. And another trial comes where it says telmisartan is equal to placebo also. That was one big controversial discussion. There were explanations came pouring in, but as you rightly said, Today, in a high risk patient, what do I use? In the entire armament, in the spectrum of ACVD, AC inhibitor, if not tolerated, straight away move to
Then,
AR.
yes, sir. If not tolerated.
Yes, sir.
So if you want to control the BP along with the protection, go with the ARB.
Yes.
Or if the BP is not a concern, then at least you should start with the all ACS patients, depending upon various subsets. In diabetic, irrespective of your BP, you have to start. Suppose if CKD, to protect the proteinuria, to protect the kidney, to prevent the progression of the end-stage kidney disease. So various pleiotropic effects are there with the ACS. So if the question is ASCVD protection, definitely yes. Some form of AC inhibition is a must.
Yeah. Moving to the last question, I think we are completing our 1 hour tenure also about the fixed drug combination AC beta blocker. I think we discussed that already.
Yes,
We
sir.
use individually, we go for the combination for the compliance and thing. Once we reach the optimal thing, I would like to listen to both the speakers available, is Siddharth also, so that we can conclude and ask Rishikesh to take over from us.
Yeah.
What do you think,
Yeah,
sir?
Dr. Sadat got disconnected, but other panelists can open.
Regarding?
This is already covered, right, sir?
Covered,
Yeah, it
covered.
is
Yeah,
already
already fixed dose
Yeah.
combination. Yeah, already I think I have answered
We are
in
covered next year.
questions itself.
Okay.
Even we have got lot of evidence, particularly when it comes with the evidence, it is a perindopril with the bisoprolol is we have got more evidence in the form of Europa trial or advanced trial or progress trial. So these trials, perindopril was added on the background of beta blockers, particularly bisoprolol. So, and one or two trials, if I am not wrong, from Ukraine, one trial, and another one is from similarly area in 2019 or something. So they have come with a single pill combination of perindopril with the bisoprolol. So we have got lot of evidence. I think around 2,400 patients or something like that they have tried. It has tolerated well. There are absolutely no contraindications. It was well accepted by the patient. So I think that was the full proof that ACE inhibitors as well as beta blockers in a single pill combination you can give. There is a lot of evidence, and these are the two. But other things, because we go with the class effect, so you can mix with other beta blockers also, like metoprolol with ACE inhibitors and all those.
Yeah.
Solid evidence is there with the perindopril with bisoprolol. If you want to go only with the evidence, start with the bisoprolol with the perindopril. No problem.
Okay.
So if there are no further questions, my pleasure that I learned a lot of good points from my colleagues, from the panelists. Thank you for MCure for giving us a nice evening. I request Dr. Rishikesh to take over from here and
Yes, sir.
conclude the session.
Thank you, sir. Thank you, sir. We are nearly at the finish line, but before we conclude, let's express our gratitude to all those who made this program possible. I would like to express my sincere gratitude to our esteemed moderator, Dr. T.R. Muralidharan, sir, for delivering the excellent session and driving the interesting panel discussion. I would also like to thank our expert panelists, Dr. Prabhu Halkati, sir, Dr. Sadat Parit, sir, Dr. Praveen JL, sir, and Dr. R. Rajaram, sir, for sharing their knowledge and expertise with us today. I would also like to thank our esteemed audience for their time, continued love and support for Cardio Colloquium program. On behalf of MCure, I extend my heartfelt thanks to everyone from sales, marketing and medical team at MCure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you, sir.
Thank you all. Happy weekend. Thank you all.
Thank you, Muralidharan, sir. Thank you, Prabhu, and other panelists, sir.
Nice meeting all of you.
After long time,
Long time.
Muralidharan, sir, after long time we are seeing you. Sometimes we
Okay.
meet in the CSI programs and all those things. But thank
Okay,
you.
good night. Good night.
Thank you.
Good
Thank
night.
you. Good night, sir. Good night.